Good morning, everyone, and welcome to all of you. And thank you to give me the opportunity, this topic to the Dr. Bina ma'am and Dr. Frederick sir. So my topic is, shall I start? My topic is Esotropia Enigma, Understanding and Managing Childhood Strabismus. So mostly esotropia, we classify accommodative esotropia, non-accommodative congenital esotropia, non-accommodative equidisotropia, sensory, and conjugativity. According to the Van Noden, the definition of infantile esotropia is manifest esodiation with onset between birth and 6 months of age in a otherwise neurological normal infant. Most consistent findings are onset from birth to 6 months, large angle, stable angle, and there is cross fixation. So when target is the nasal side, she's using the eye in the right eye, and the right target is there. This is using the left eye. So that is the called cross fixation. And there is no abduction restriction. There is asymmetrical optokinetic nystagmus. Important association findings are inferior oblique overaction, dissociated vertical deviation, nystagmus, and pursuit asymmetry. So inferior oblique overaction is commonly associated with the congenital esotropia. About 70% of the cases we see in the supra-adduction position. So here is the, we see in the supra-adduction position in the both eye, there is inferior oblique overaction. It's not 50% of the esotropia is associated our dissociated vertical deviations when now is closed one eye. So it is upward, outward, and exo deviations, and it is slowly drip downward. So here also oblique muscles, inferior oblique muscle is overact. And when you see that in the supra-adduction position, there is both inferior oblique muscle is overact. Nystagmus is all type of nystagmus is associated with the congenital esotropia, latent nystagmus, manifest to latent. All three are associated with this. So in latent nystagmus, first piece veers towards the site of fixing eye, and manifest nystagmus is amplitude increase when the eye is covered. Pursuit asymmetry when the eye is occluded, and moving toys from one side to another side. So temporal to nasal, the pursuit will be smooth, and nasal to temporal, there is absence of pursuit or jerky movement. That is called cogwheel. These are the differential diagnosis of esotropia. So you have to exclude that sensory esotropia to see the fundus, any optic atrophy is there or not, retinal detachment, corneal opacity, and our cataract. Type 1 DRS, you have to exclude from congenital esotropia to see the any profound restriction is there in the type 1 DRS. And we see the upshoot, downshoot, and globe retraction. Next differential diagnosis is sixth nerve palsy. It is very rarely occur. If it occur also, it is reversible. These three, that is sixth nerve palsy, DRS, and congenital nerve palsy. Then that is esotropia. You have to differentiate by extraocular movement by the doll head maneuver, patching the one eye to see the extraocular movement for 45 minutes, or you have to do the forced reduction test under general anesthesia. Early onset accommodative esotropia. Here it is not like congenital esotropia. No, it is larger, stable angle is there. But here it is a intermediate small angle and hyperopic shadow. And with glasses, the eye become ortho. Another differential diagnosis is the Mobius syndrome. Here both the eye will be lateral rectus pulse is there. Other associated finding like facial nerve or paralysis and hypergosum nerve is involved here. And here is the congenital fibrosis of extraocular movement. The all extraocular movement is there is restriction in that along with the horizontal and vertical. And due to the ptosis, that is lip, that is chin elevation is there. So that is why we exclude from the congenital esotropia. In other differential diagnosis, the epicanthal, that is pseudostrabismus, we have to look epicanthal for broad nasal breeze, short interpupillary distance. So these are all the differential diagnosis of esotropia. So what is the management? So management is always surgery. So before surgery, we have to see the refractive error is there or not. Any refractive error more than +1 diopter, you have to prescribe the glasses and reassess after 1.5 months. And if any amblyopia is there, then you have to treat accordingly, either patching alternate, or one eye is there strabismus there, you have to do the dominant eye patching. And because the failure to treat the amblyopia will compromise the surgical alignment. And time of surgeries is between the 6 months to 2 years of age. If beyond the 2 years, then there is chances of peripheral fusion is very less. And goal of treatment is excellent visual acuity in both eye, perfect single binocular vision, and a normal aesthetic appearance. And indication for surgery is stable, large angle deviation, and absence of any accommodative factors, and eye always alternate fixation. And type of surgery, bilateral medial rectus recession or unilateral recession procedure for the on the non-dominant eye. If inferior oblique muscles overaction is there, DVD is there, then you tackle according to the inferior oblique, either weakening procedure or both is there, then anterior positioning of the inferior oblique muscle. Then coming to the sensory esotropia. So it is caused by the unilateral reduction of the visual acuity. Most causes are corneal opacity, cataract, optic atrophy, macular scarring. Next is the accommodative esotropia. So accommodative esotropia is caused by the accommodative effort, and excessive effect of accommodation result in inward deviation of the eye. So most age group are not like congenital, like it is the 2 to 3 years of age. And ocular deviation is esotropia to esophoria to esotropia, and mostly associated with amblyopia, and sometimes child were complaining of diplopia and with the variable angles. It classifies refractive, non-refractive, partial A, and hypoaccommodative. Coming to the mechanism, when uncorrected hypermetropia is there, no, so there is retinal image blurring is there. Due to that, accommodation occur, followed by accommodation conversion. Here two types there. So if the sufficient fusion or diversion is there, then there is eye is isophoric. If insufficient fusion is diversion is there, eye become esotropia. So that is refractive accommodative esotropia. And sometimes retinal image is blurred, but there is no effect of accommodation. The eye is orthophoric, but the patient will go to ametropic amblyopia. This is the mechanism of our accommodative esotropia. So then refractive accommodative esotropia, the hyperopia is the +2 to 6 diopters. Angular deviation is the minimum, that is 20 to 30 prism diopter. Here is the clinical scenario. The 3 years of child is esotropic, 30 to 35 prism diopter. After cyclophagic refraction, we got 3.5. We give the glasses, and after glasses wearing, the eye become orthophoric. Similarly, 7 years of female child, minimal esotropia is here. So after giving the glasses, eye become ortho. Next is the non-refractive accommodative esotropia. So here what happens? So all type of refractive error is associated. Ametropic, hypermetropia, myopia, astigmatism. And deviation is only at the near or more at the near. And here the high AC/Y ratio is there. So every diopter of accommodation have some prism diopter of conversion here. So here is the clinical scenario. Distance we got the 7-year child. So 6 prism diopter. 6 prism is there. Near it is 25 prism. And after the 3+ diopter, near is 4 prism. So with gradient method, AC/Y ratio is the near we got 25. And +3, that is 4 divided by 3. Whatever you use the lens that we have to do. Suppose you use the 2.5, then 2.5 here also. So 25 minus 4 divided by 3, it is 21 by 3, that is 7. So normal AC/Y ratio is our 3 to 5. So here is 7. So it is high AC/Y ratio. So we prescribe the glasses bifocal, and always straight line will be that should be bisect the pupil. Then move to the partial accommodative esotropia. Here the residual esotropia present after the prescribing the full cyclophagy refraction. And age group is 1 to 3 years. Small angle, that constant amblyopia is present, BSP also lost. And all type of refractive error is there, astigmatism and isometropia appear, and that is associated with the vertical deviation. So treatment part is correction of the accommodative part with isotropia with glasses. If amblyopia is there, you have to treat accordingly. And measure the full correction, both near as well as distance. And for the non-accommodative part, you have to do the surgery, but above the 20 pgm diopter. So here is the flow chart. So isotropia, full cycloplegic correction. So orthophoria for both near and distance, that is called refractive accommodative isotropia. Orthophoria for the distance, but not for the near. The AC/Y ratio will become high. That is not refractive accommodative isotropia, that is used the bifocal. Next is the if deviation is reduced, but there is no orthophoria both the distance and as well as near. That is partially accommodative isotropia. The non-accommodative part, we have to do the surgery, and accommodative part, we have to give the classes. Another type is that is acute committant isotropia. This is mostly seen in the 5 to 6 year babies, sudden onset, and children are complaining of diplopia. Normal ocular motility is there. There is no significant refractive error. And that child, you have to always do the MRI scan to rule out any neurological deficit. And treatment of choice is if it is small, then choice of treatment is the botulinum injection, but larger is there, then we plan for surgery. But before the surgery and botulinum, we have to check the refractive error with the cycloplegia refractive. It should be below 5 years, you do the atropine refraction. Above the 5 year, you do the cyclopendulum. Any refractive error is there, then you have to first correct that one, and then you plan either surgery or botulinum toxin. Thank you.